Amy, I've heard that there are several levels of hospice care. What does that mean? I mean, levels of hospice?
So there are 4 different levels of hospice care. The first level is routine hospice care. Typically, about 90 to 95% of your patients will fall under routine hospice care. The patient can be in a private home, personal care home, skilled nursing facility, assisted living facility. The national average standards for visit, typically a nurse would see them 2 to 3 times per week. The home health aide would typically visit 3 to 5 times per week. Social work and chaplain would typically see the patients about 2 times per month. Under routine hospice care, the hospice pays for the meds, supplies, and medical equipment related to the hospice diagnosis. The next level of hospice care is general inpatient hospice care. General inpatient hospice care has to be done in a hospital, inpatient hospice facility, or a skilled nursing facility. The hospice contracts with the facility to provide a higher level of hospice care. Under general inpatient hospice care, the patient is seen daily by the hospice nurse. Typically, the social worker and the chaplain sees the patient 1 time per week, and all of the meds, supplies, and medical equipment are supplied by the facility because the hospice then assumes the responsibility of the room and board for that patient. Inpatient hospice care goes until the reason that they were put on inpatient hospice care is resolved, typically about 10 to 14 days. Respite care is for a patient that lives in the community and maybe their family needs a break, maybe the family's going on vacation. It is for 5 days. It is done in a skilled nursing facility and they are seen every day by the hospice nurse. Continuous care is the 4th level of hospice care. That is 24/7 around the clock care. It is a midnight to midnight benefit. So you have to have at least 8 hours of hospice care that you're providing from a midnight to midnight period in order to qualify for continuous care. It's for uncontrolled symptoms, nausea, vomiting, diarrhea, seizure, something that is uncontrolled that requires an RN to be present and monitoring that patient.
So that's the highest level
Correct.
of care, and that can be done in-home?
In-home.
And that's not including the facility?
That's correct.
So when we talk about traditional patients, are they usually does it matter what level they come in, or do you discuss that with the family before putting together their individual or tailored plan?
We do. Whenever patients are electing for hospice care, we sit down and we discuss all of the levels of hospice care available so that the patient is brought on to hospice under the appropriate level of care. And during their hospice stay, if you have a community patient living at home and they have an exacerbation of pain or they need something managed, they can go into a skilled nursing facility under inpatient care, come back out to the community. They can go from home to respite, come back out. So they can go in between the different levels of care.
You've been doing this for a very long time. I know you have a lot of stories. Can you share with me at least one story where you had a family? I mean, it's difficult for all families, I think, coming to the realization that, maybe this is end of life management of symptoms and end of life care. Can you tell us one story where you felt that hospice was truly beneficial to this family, that you remember, that stands out, and where the continued relationship you think was very special and you were able to help this family transition?
That's a tough question because working in hospice for the past 17 years, you meet a lot of people. You become part of their family because you're there so often and you dearly care for these people. I've seen couples that have been married for 65 years and one of them is dying and the other one is sitting there holding their hand and they're devastated. It's like losing half of yourself. And they're sitting there and being a witness to that true love. It truly makes you realize how precious life truly is. And it almost makes me wish that we could take young people today and sit them in front of these people and witness this, because I think that there would be a lot less divorce. I think if people truly valued relationships like these people did, having been together for so long. But I did have a woman who was 39 years old. She had breast cancer. It had spread to her liver, lung, her bones, and her brain. She had 3 children, 15, 7, and 9. She started off with hospice care at home, and as her condition progressed, she ended up going inpatient at one of our contracted facilities. It was very difficult to watch the transition and watch her have to part from her children. But in the end, our social workers, our chaplain, our volunteers, we work with the families to prepare them, but I don't think anybody is ever truly prepared. We do have a bereavement program that goes for 13 months after the death. So when a patient dies, our bereavement program starts. It's visits, cards, letters, just to help the people get through. And we do 13 months because that 1 year mark is a very difficult time, and that extra month helps to pull them through.
I mean, everybody's experienced death of a loved one, of a friend, of a relative. And I think it's interesting when you talk about the younger generations, they run in the opposite direction of hospice care. They, especially even nursing, they start nursing and this is not what they want to do because they're scared. They're scared of a realization. So I think it takes a very special person to be able to work with these patients and specifically to be able to provide the support. And one of the biggest things is at the end, when you provide end-of-life care, which a lot of people don't understand, is you're doing something amazing and you're doing something great for someone who can no longer repay you. And to provide that support for the family ongoing, you're taking care of their emotional being, which is something that loved one who has passed would have wanted and can no longer provide that support. So it's an amazing industry. It's, it's no surprise that there's so many volunteers. But I think sometimes it's under-recognized. You don't really hear about the wonderful things that hospice nurses are doing every single day out in the field and how they're caring for not only the patient during the most difficult times. And like you said, if we take care of their comfort measures, at the end, the sadness is not in the physical pain. The sadness is more in the love, and the loss. So that's very important to recognize, and that hospice is really there to provide an emotional and spiritual support more than anything, whether it's the emotional spiritual support to see an improvement, and there's improvements every day because we've heard of medical miracles and it happens, or to provide that emotional support at one's end of life. And I think that, when we look at hospice as more of in that light, then we're not really looking at these nurses as standard nurses that are coming in and giving you shots, but you're really looking at them as angels and they're coming to help you. So, I really appreciate, having this conversation and enlightening a lot of people about just the importance of having that support at home, because ultimately, that's where everybody wants to be.
Ironically, you mentioned at home. When I talk to people about hospice, I always describe to them the perfect hospice death. And initially, people look at you a little funny and they think, perfect hospice death. Okay. So I had a gentleman who I was working with. He actually owned a hospice agency. And I told him that when I started to start his agency. And he looked at me a little funny until we had his grandfather on the hospice service. When his grandfather died, he came to me and he said, I get it. I get what you're telling me about the perfect hospice death. The perfect hospice death is when you have a patient at home. They're in their bed, they're surrounded by their loved ones, and they're passing. There is a nurse there, typically in another room, available for needs, comfort, anything, but in an arm's reach from the family. But the family is surrounding the bed, and it's such an intimate part of one's life. I actually see it as an honor to be able to be there for that time.
And, being there at home, so many don't get the opportunity. When we talk about aging and we talk about shying away from aging, it's such a gift, I think, to be able to age and to be able to age gracefully and to have the family around you. And then ultimately, what a gift it is that once you've lived a full life, and some are not that fortunate, people have not been granted that gift of a long life, but if you were given that gift and you are at home and you have your family around you, and then there's this organization that essentially facilitated the ability for you to be at home and to receive that care, so that, you know, the final memory for either you or your family is to be in a place that you felt most comfortable and that you're not in this facility. And I think that, you know, we need to get away from institutionalizing. I talk to doctors all the time. I say, even with nursing and rehab, how many people actually have to be there? And unfortunately, it's a very small percentage. You know, most can be at home. So why not take advantage of the services that are out there today that are going to bring you home and provide those services for you?